Let's read about the treatment of hyperthyroidism in pediatrics from Indian Academy of Pediatrics Guidelines 2022. Hyperthyroidism. I'm just gonna read, okay? So if you just wanna listen passively and make notes, let's move ahead. Hyperthyroidism, production and secretion of excess amounts of thyroid hormone from the thyroid gland. This is called as hyperthyroidism, and that is when the thyroid hormone is being produced from the thyroid gland. Okay, and thyrotoxicosis, the hypermetabolic clinical syndrome which occurs when there are elevated serum levels of T3 and T4. It is a hypermetabolic clinical syndrome when there are elevated serum levels of T3 and T4. In hyperthyroidism, there was thyroid hormone increase from thyroid gland, but here there is elevated level of T3 and T4. Okay. Now hyperthyroidism accounts for 10 to 15% of the thyroid disorders in children. Age at presentation, it is less common in children less than 5 years, and peak incidence is at 10 to 15 years of age. Okay, hyperthyroidism, and it is more common in girls. Let's look at the etiology. There is circulating thyroid stimulators. Etiology, hyperthyroidism is caused due to circulating thyroid stimulators, which is seen in Graves' disease, neonatal Graves' disease, and TSS producing pituitary tumors. So these will circulate in the blood and stimulate the thyroid gland to produce more thyroid hormones, producing hyperthyroidism. Okay, and in thyroid autonomy, single or multiple nodules are present, or McCune-Albright syndrome, or congenital hyperthyroidism. And thyroiditis, Hashimoto's thyroiditis can be seen, and exogenous thyroid hormones, the factitious or iatrogenic. Now coming to Graves' disease, accounts for more than 95% cases of hyperthyroidism. This is something that we should know, that in most of the cases it will be Graves' disease. It is an autoimmune condition and is caused by a complex interaction of genetic, environmental and immune factors. Okay, it is an autoimmune condition, that's something that we should know. Thyrotropin receptor antibodies stimulate the thyroid stimulating hormone receptor and increase the thyroid hormone production and release. Okay, so there is something called as the thyrotropin antibodies which stimulate the TSH receptor. Okay, they stimulate the TSH receptor and it increases the thyroid hormone production and its release. A family history of the autoimmune thyroid disease may be present. Okay. The most common clinical features of hyperthyroidism among children are weight loss, palpitation, and anterior neck swelling. Okay, these are the three most common features of hyperthyroidism among children. What? Weight loss, palpitation, and anterior neck swelling. While older children are also commonly present with the sleep disturbance, poor scholastic performance, and easy fatigability, increased stool frequency may be commonly seen in younger children. Okay, because the gut motility is increased. Other symptoms are excessive sweating, tremors, hair loss, and headache. The features of ophthalmopathy like lid retraction and scleral injection and proptosis are reportedly less common among the children. So what we read, children will most commonly present with weight loss, palpitation and anterior neck swelling, while the older children present with sleep disturbance, poor scholastic performance and easy fatigability. Increased stool frequency may also be seen. Then other symptoms include excessive sweating, tremors, hair loss and headache. The features of ophthalmopathy like the lid retraction, scleral injection and proptosis, they are less common in the among children. Okay. To establish hyperthyroidism, there is a mechanism. What is the mechanism of hyperthyroidism? Thyroid gland is producing more T4 and T3, so it will give negative feedback to the pituitary gland, which will reduce the TSH. So on presentation, if a patient presents to us on a non-thyroid profile, we will see TSH will be suppressed and free T3, T4 will be raised. To find out the cause of hyperthyroidism, thyrotropin receptor antibody. This should be done, and it is usually raised in Graves' disease. We saw in Graves' disease is most commonly the cause of hyperthyroidism. It also helps in predicting the risk of relapse after stopping the antithyroid drug. Okay. It also helps in we can predict the risk of relapse after stopping any antithyroid drugs. Then technetium 99M scan of the thyroid gland. It shows increased uptake in the Graves' disease. This can help differentiate between Graves' disease and Hashimoto's thyroiditis. In early stages, due to the release of preformed thyroid hormones, there could be hyperthyroidism. However, there is decreased uptake on the thyroid scan. This is the figure 2. Okay. So why we are using technetium 99M scan is to differentiate the cause of hyperthyroidism, whether it's Graves' disease or Hashimoto's thyroiditis. Okay. Now let's see on ultrasonography. There is usually a diffuse enlargement of the gland is visible, increased vascularity, and helps in ruling out the solitary nodule and multinodular goiter. Okay. Other investigations that we can do is CBC, liver function test to be done before starting any antithyroid drugs, and fine needle aspiration cytology. This is required only if malignancy is suspected during the evaluation of diffuse goiter or thyroid nodules. Okay. Now coming to treatment part. So the initial goal of therapy is the control of symptoms and normalization of biochemical parameters. Fine. We have to control the symptoms and normalize the biochemical parameters. Definitive therapy is considered among children who fail to produce early and long-standing remission. Now let's look at the algorithm for management of hyperthyroidism. Clinical and laboratory evidence of hyperthyroidism are present. Then start beta blocker for the symptomatic relief because the patient will have high blood pressure. And if there is diffuse goiter or nodular goiter, we have to differentiate in these. In diffuse goiter, we have to start the antithyroid drugs with close monitoring. Remission achieved over 1 to 2 years of therapy. Okay. And if there is a nodular goiter, definitive surgery or radioiodine ablation preferred among adolescents. Fine. First we have to do is this. So this that we read recently, radioiodine ablation or surgery, they are the definitive therapy, right? So they are preferred among adolescents in case of any nodular goiter. But if there is diffuse goiter and there is remission achieved over 1 to 2 years of therapy, then it's good. If the remission is not achieved after 1 to 2 years of therapy, then also we can go for this definitive therapy, that is surgery or radioiodine ablation. Fine. And if remission has been achieved, then we can taper, titrate and stop the treatment. Now let's move ahead. In the treatment part only, the preferred initial therapy for children with variety of etiological causes is antithyroid drugs. Methimazole is started initially at a dose of 0.1 to 1 mg per kg per day, or carbimazole at the dose of 0.5 to 0.7 mg per kg per day is preferred over propyl thiouracil among children. Fine. The relevant details are given in this table, so let's read them. Fine. Antithyroid drug treatment option for hyperthyroidism. What we can do is start with antithyroid drugs. Patient preferred. What are the advantages? Patient preferred effective initial control. Fine. And disadvantages: risk of adverse effects, limited chance of complete remission. Remarks: the chance of achieving remission gradually increase with the prolonged therapy. Second therapeutic option is radioiodine ablation. Option for patients trying to avoid surgery. Okay. Then takes several weeks to achieve remission. This is the disadvantage, and not recommended for children less than 5 years of age and not preferred for children 5 to 10 years of age. There is risk of relapse also, and in long term suspect risk of developing malignancy. So this is not supported with literature, but there are chances of malignancy in long term with radioiodine ablation, and require lifelong monitoring and replacement for hypothyroidism. Now last one, is surgery, total or subtotal thyroidectomy. Immediate results preferred among children with the nodular goiter, and disadvantage is risk of developing hypoparathyroidism. Experienced surgeons are recommended for good results, right? Because during the surgery, parathyroid gland may be removed, so this will result in hypoparathyroidism. The dose of anti-thyroid drug is titrated with goal to achieve free T3 and T4 estimation within the normal range. Addition of beta blockers like propranolol in 1 to 2 mg per kg per day helps in the early control of symptoms, and the dose can be titrated based upon the reported symptoms. Fine. Then, if remission is not achieved, anti-thyroid drug can be safely continued over 1 to 2 years of duration, after which the definitive therapy, either in the form of radioiodine ablation or surgery, should be considered. If remission is not achieved, then this is the case. After that, after 1 to 2 years of duration, after starting the anti-thyroid drug, then we have to consider definitive therapy, which includes radioiodine ablation and surgery. We read about both the advantages and disadvantages of that. Surgery and radioiodine ablation are preferred over anti-thyroid drug among hyperthyroid children with toxic nodule or multinodular goiter. Now, monitoring and follow-up. Free T4 and T3 should be estimated every 4 to 6 weeks for the initial titration of anti-thyroid drugs. Okay, so it should be done every 4 to 6 weeks, almost every monthly. Once the euthyroidism is achieved, 3 monthly monitoring is optimal. Fine. When the levels of T4 and T3 are normal, within the normal range, then we can go for 3 monthly monitoring. The baseline CBC and the liver functions should be checked before the initiation of anti-thyroid drugs. So what should be done before is the CBCs and the LFT. Children should be clinically monitored for the potential adverse effects of the anti-thyroid drugs, which are, so adverse effects of the anti-thyroid drugs include urticarial rash, agranulocytosis, hepatic dysfunction, arthralgia, and other vasculitis associated symptoms, which may warrant repeat laboratory testing. If the surgery is chosen as definitive therapy, the calcium and parathyroid hormone levels should be closely monitored during and after the perioperative period for timely supplementation with calcium and calcitriol. So what this point was, if surgery is chosen as the definitive therapy, then we have to monitor the calcium and parathyroid hormone in case during the surgery there occurs any damage or injury to the parathyroid gland. So we have to monitor prior to the surgery calcium and parathyroid hormone, and so that we can timely supplement the calcium and calcitriol. Fine. After the radioiodine ablation or thyroidectomy, the thyroid status should be monitored with the free T4 and TSH levels for guiding the replacement doses. Fine. Now the outcome. Some children with the milder presentation of hashitoxicosis show good symptom control over short therapy with only beta blockers medication. Mild presentation of hashitoxicosis can be controlled only with beta blockers. Others may require few months of anti-thyroid drugs before achieving complete remission, which is usually present. Almost 1/3 children with the Graves' disease achieve complete remission after initial anti-thyroid drug trial, and there is a considerable risk of relapse once the anti-thyroid drug is stopped. Fine. So almost 1/3 of the children with the Graves' disease, which was 95%, which was the cause of hyperthyroidism in children 95% of the times, and complete remission after the initial anti-thyroid drug is considered, but there is risk of relapse once the drug is stopped. Hence, family should be provided with the options for definitive therapy in early course of the disease. After RIA or thyroidectomy, children need lifelong hormonal replacement for hypothyroidism, because in radioiodine ablation the gland is, I think, completely removed, and in thyroidectomy it depends which type of surgery is being done, but still we need to supplement hypothyroid hormone for the life. This was all about the management of hyperthyroidism according to Indian Academy of Pediatrics. Thank you.